Hello, my name is John. I'm making a video on advocacy for patients with glioblastoma. The reason why I'm making this video is because there has been a phase 3 clinical trial that's been completed, and now after that there's been a peer-reviewed article that's been published in the Journal of American Medical Association, and that's one of the big steps before it gets presented to the FDA for a potential request for approval. In the FDA in Health Canada and over in the EU. And the reason why I'm sharing this this information and maybe adding something to it is because there is a identifiable patient population that benefits from this vaccine that's been explored through this phase 3 clinical trial in the journal article. And there is a patient population there's a patient population that benefits from this vaccine, but I'm also hoping to show that there's also a way to expand on that, and that's a theory of mine, but and even though I'm not a doctor, I don't have any formal medical education, I think it's probably going to be developed by doctors anyways already without me even saying this, but if I can just maybe add to some of the hope for some patients that are being treated with glioblastoma, that I can share this, and it's all good news really. So what I'm sharing, and I'll back that up with some presentation slides from important researchers on this vaccine, is this vaccine is called DCVax. It's being developed by Northwest Biotherapeutics, and it's completed a phase 3 clinical trial, 331 patients in 4 countries, and they've already gone circles around this vaccine. They know who it benefits, they know who it doesn't necessarily benefit from it, and there's also people that will get a positive response from this vaccine, but I guess it might not be long-term survivorship without any additional interventions, at least anyways. And so, yeah, going back to the reason why I'm making this video is to share that what I think, and again, I'm sure what doctors will share, is that there is a patient population that benefits from this vaccine. It's a very good number, but there's nothing crazy, but you can also expand on that number as well. And I don't want to say just like this very second, but I'll explain that through the video as to how the long-term survivors from this clinical trial on DCVax could actually be a lot bigger than what was reported. So it was reported that 13% of patients from this 331 patient clinical trial had lived at least 5 years on average, and that's a good number. And then they've established that 13% of patients, they belong to a certain subgroup of genetic expression type patients, and this is sort of a introduction to immunotherapy. So in immunotherapy, in those conversations, it's going to be discussed what type of genetic expression that patient's tumor has. So it could be one of 4. There's 4 genetic expressions. Sometimes it's brought down to 3 in some circles, just because they can combine the two. But generally speaking, there's 4 genetic expressions for patients with glioblastoma. There's mesenchymal, proneural, neural, and classical. The reason why I'm sharing this is because the patients with the mesenchymal gene expression are the patients who did very well in this clinical trial. And what I'm going to show is that was published in scientific journal articles and presentations that it was the mesenchymal gene expression patients that benefited the most from this vaccine. And then I'm also going to go, I'm not going to say off script, but I'm going to pull from other scientific journal articles that show that a person who is not in the mesenchymal gene expression can go into the mesenchymal gene expression through treatment. And I think, and this is, I'm not a doctor, I don't have any medical education, but I think that in doing so, by getting treatment to get into that genetic expression, that will expand on the 13% survival rating for patients with glioblastoma, and you're going to see a lot more people living longer with this disease if it is approved, if the vaccine is approved. So what I'm going to show you now is a video is by the Seattle Science Foundation. The speaker is Linda Liao. She is the original creator of this vaccine. She is the current president of the Society Journal of Neuro-Oncologists. She's the former editor-in-chief of the Journal of Neuro-Oncology, and she works out of UCLA. She treats patients. She works in the lab. She does the surgery. She does the neuro-oncology. She developed this vaccine. UCLA licensed this vaccine to Northwest Biotherapeutics. They're a biotech in the USA. And I'll show you in this video. It's just going to show that the survivors from this vaccine are patients in the mesenchymal gene expression from her initial observations, and that's all what this clip is going to show.
Institutional controls matched, matched for age, extent of resection, all that, which was only 21%. But as you can see, the difference is not necessarily, in retrospect, it's not the median survival, it's really that tail end. So that tail end in this particular case was almost 30%, and I can tell you a lot of those patients are actually still alive. So that's actually what intrigues me the most, who are these tail end patients, and how can we identify them? So with that, you get to thinking, well, what is different about these patients' tumors? So I'll tell you about two of the first, cohort of patients. So this is, patient number 1, and this was actually patient number 3 in the clinical trial. Both had, left temporal lobe tumors. Both underwent gross total resection. So, they had the minimal disease, for prior to initiating this trial. They both had standard treatment with radiation and temozolomide, and then they subsequently enrolled in this clinical trial. And you could see the demographics are very similar between the two. The first patient was 39 years old, second patient 34. Both male, good Karnofsky performance score. They both had small kids. When I met them, it was actually a very eerily similar type of patient. Histologically, if you looked at their pathology, they looked identical. You really couldn't tell anything on histology that was different between these two patients. But you could see the overall survival was significantly different. So the first patient, his overall survival was 33 months, almost 34 months, whereas the second patient was, at the time we published this paper, over 8 years, and actually this paper was published quite a while ago. He's still alive now, going on 14 years. And we've had several of these patients. And this particular patient actually had activation of a CMV-directed T-cell response, and I'll show you that. But what was curious is, well, what is different about, patient 1 versus patient 3? And one thing we did look at was gene expression profile. For those in the field, glioblastomas are now classified into different subgroups, proneural, classical, mesenchymal. So, one criticism of this trial is like, well, maybe you just enrolled all the proneural, patients, the good subgroup patients, and that's why you're getting longer survivals in these patients. So we looked at that, and interestingly, that wasn't actually the case. So patient number 1 was in that top cohort of patients. He lived 33 months, which was actually higher than the normal or average, median for glioblastoma. But it was actually not that much different than what would be expected for his subgroup, proneural subgroup, IDH1 mutated, MGMT methylated, those good prognostic factors. He kind of lived as long as probably would have been expected given his molecular subgroup. Interestingly, the patients who actually saw the most benefit from immunotherapy was in the mesenchymal subgroup, and that's actually the poorer subgroup. Those are the ones that are IDH1 wild type, MGMT not, methylated or non-methylated. It actually was in both populations. But those are the ones who typically have a median survival of about 14 to 16 months. So in that group, the vaccine actually did seem to show a significant difference, and actually all our long-term survivors were in the mesenchymal subgroup. So there's something about that particular subgroup that I think is inducing a better perhaps immune response for these patients, and that's kind of what we've been studying for the last 5 or 6 years now. So things that seem to correlate with this is that they do seem to be increased with increased tumor infiltrating lymphocytes. In our initial trial, we saw that those with increased lymphocytic infiltration do better. So it seems to be the case for this, but it wasn't actually just the lymphocytic infiltrates after vaccination, because we didn't, many of these patients actually didn't recur, so we actually have never gone back to take out tumor. But it's actually the lymphocytic infiltration before vaccination. So patients who tended to have some T cells in their tumor before entering the trials actually seem to do better. So this is probably a more immune responsive subgroup, a subgroup where, there is some initial immune response and maybe it just wasn't enough, and immune therapy could make a difference in this particular subgroup.
So there was the video from Dr. Linda Liao explaining how there are long-term survivors with this vaccine in the mesenchymal gene expression. She mentioned at the time, that was early on, so it was about 30% of patients were long-term survivors, it was 3, 4, 5 years. Since then, some people have passed away, and I can address that as well. That long-term survivorship has gone down to about 13% that are still alive over 5 years, which is still a jump from the regular standard of care, which is 5%. So what I wanted to share now is in order to expand on the mesenchymal gene expression and get more people in on the mesenchymal gene expression, and I know it's not like a bus or anything like that, or it's not like a house party, but to get more people into the gene expression, you've heard it in chemotherapy, sometimes if you take too much chemotherapy that it stops working a certain way, so patients will develop different mutations and it won't work on the patient. That's sort of the same idea with this immunotherapy. With immunotherapy, the person's gene expressions will be characterized by things like what kind of mutations they have. That's one of the undisputable cornerstones of defining a patient's gene expression, is what mutations do they have in their cancer. And so, but that also changes. Those gene expressions can change, like I just mentioned, like chemotherapy can change someone's gene expression. And so I'm thinking that if everything aligns, we can use that to our benefit. Again, I'm not a doctor, but I just want to say there is a drug out there that's already FDA approved, and it's even for glioblastoma patients, so it won't even have to be off-label. It's called Bevacizumab. and the I guess the brand name is called Avastin, and that's been known to alter a patient's gene expression so that it transitions into the mesenchymal gene expression. And so that is something that I wanted to convey, and I'll show this right here on the next slide. Is that when someone hears that, oh, you might have like a 13 or 15 or 20% chance of being a long-term survivor with this vaccine, that I think that the way the science is going to go is with bevacizumab, you can introduce that into a patient's treatment protocols. Their gene expression will change into the mesenchymal gene expression, and then the patient would be at that point in time more susceptible to be having a better outcome with getting DCVax. And I'll show that the literature here showing how bevacizumab can change the gene expression. This article, written in 2017, shows that bevacizumab will induce a transition into the mesenchymal gene expression. And this isn't anything new. Any doctor's office that deals with glioblastoma patients will tell you that when you're introducing avastin or bevacizumab, it's kind of one of the last things that's introduced into the treatment protocols, because yes, it does work. It does work very well for several months. But eventually what happens is that the cancer will spread after the drug loses its efficacy. And one of the proprietary characteristics of the mesenchymal gene expression is that there is a spread to different areas in the brain of the tumor. And again, that's kind of a last thing. That's like one of the last things that happens for a glioblastoma patient when they take Avastin, that the tumor does spread. But that's the reason why I'm showing you this article is that there is science behind it. The community, the brain cancer community, does know that Avastin can and will induce a patient into the mesenchymal gene expression. And this is just another screenshot indicating that patients with the mesenchymal gene expression have a better result after taking DCVax. And this article was written around the same time as the Linda Liao presentation, and it is tied into her study. It's just coming from a different author. So that's pretty much all I wanted to share for this video. Is just that if someone hears that there's only a 13% chance of survival, 5-year survival with this vaccine, that it is possible that hospitals could improve on that by introducing bevacizumab to care. That's potential, at least in my mind. I also want to share that this vaccine does require frozen tumor tissue. So potentially a second surgery may have to be planned. I'm not sure how that works, but the way the vaccine is created is that it's tumor tissue is resected from the patient, it's frozen, and then it's given to the lab, and they make the vaccine based off of live frozen tumor tissue. So that tumor tissue is from our initial diagnosis. Can they make that into a vaccine 2-3 years down the road and have it be effective when we're changing the gene expression? I don't know. There's a lot. There's a lot in play. There's does the new gene expression, does that create a more hospitable environment for white blood cells because they can infiltrate more into the tumor. That's what Dr. Linda Liao was saying. And so maybe it doesn't need those specific mesenchymal antigens from the new updated tumor. You can use the old one, or yes, we do require new tumor tissue. So I don't know about that one. But I will do more videos. There's actually, they say that there are some patients who were in the mesenchymal gene expression that still passed away, but there's actually other studies that are just as promising that show that third immunotherapy can be introduced to emphasize the use of the vaccine. They can kind of concentrate it. They basically off-label. It's called imiclamod. It's a skin cancer treatment. It's a cream. You put it on your shoulder. White blood cells go to that site of application, and 24 hours later you get the vaccine. So what you're doing is the vaccine will go to this area where now you have a huge concentration of white blood cells and all these naive white blood cells, and now we're putting the vaccine in that site, and what the vaccine is doing is it's sharing target information to all these naive white blood cells, and so you have this army of white blood cells armed with this targeting information, and it finds its way to the tumor site. And they actually did a 9-patient study, and I think it was like 50% of patients were living like 5-6 years, and that was actually with one dose of the vaccine, and you can get more than one dose. So that is like a whole new major development. I'll share references, screenshots. I'll share everything that I can on that, and kind of format that in a way that it's kind of that it makes sense. Just not me rambling. But I did want to share that, so I'm going to put that video sometime in the next couple of weeks. And that study was actually done by Dr. Linda Liao as well. So it's you're building off of some really good work, and then there's some more good news coming along the way. So that's it for this video, and I'll make a new one soon. Sounds good.